Welcome back, guys. Today we're going to talk about the peptic ulcer disease. So, the peptic ulcer disease, first of all, we're going to talk about the pathology of the peptic ulcer. It's dependent on the HCl secretion and the mucosa production as well. So, if the HCl secretion keep digesting the mucosal layer, so the mucosa facing that by continuous production of the mucosa. So what happens if the HCl increase? There is imbalance will happen, and the HCl decreases more mucosa, and the HCl will reach the lower layer of submucosa and muscularis, and this will cause the peptic ulcer disease. And what happens if the HCl keep normal, but the mucosa production decrease in production? So the HCl also will decrease the mucosa here and will reach the lower layers of the stomach as the submucosa or muscularis and adventitia. Let's take a look about the peptic ulcer type. They divided in two types. First type is a gastric ulcer here, and the duodenal ulcer, which depending on the site of the ulcer. But the difference between these two types is about the presentation of the patient, because the gastric ulcer will greater pain with the meal. After eating, the pain will increase. Unlike the duodenal ulcer, with the pain will decrease after the meal. And also there is a weight loss for the patient because the patient will avoid eating, decrease his eating. That's why there is a loss of pain. And the duodenal ulcer will weight gain because the patient tries to eat more to decrease the pain. Also, it is associated with H. pylori of 70% in the gastric ulcer and 90% with the duodenal ulcer because the HCl secretion increasing with the H. pylori. The H. pylori itself enhancing the stomach but to increase the HCl due to alkalization of the media in the stomach. That's why the stomach tries to increase the more HCl, which that affecting more the duodenum more than the stomach, but also still affecting the stomach about 70%. So also we have a mechanism of the ulcer here, as I said before. Decrease the mucosa production in the gastric ulcer only, but the duodenal ulcer affected by increasing the two types. The main cause of the gastric ulcer is non-steroidal anti-inflammatory drug because it's decreasing the mucosa mainly and not increasing the HCl. But the Zollinger-Ellison syndrome here, it is a syndrome of increasing the gastrin. We call it gastrinoma. So it is increasing the gastrin, so that will of course increasing the HCl. Risk of carcinoma in gastric ulcer is more increased, but in duodenal ulcer is generally benign. Biopsy of the margin to rule out the malignancy because the ulcer it has a edge like a cancer, so that's why they take a biopsy to differentiate between it and the cancer. We have three major complications for the ulcer in general. We have a hemorrhage, obstruction, and perforation. So we have other complications like iron deficiency, anemia, and other things. But here we have a hemorrhage. It's the most important complication because they keep asking about it in the UWord and USMLE exam. The hemorrhage usually in the gastric more is posteriorly more than anteriorly in both gastric and duodenum. But that means that the artery will affect it. It is posterior artery. So rupture of gastric ulcer here in the lesser curvature, that means the bleeding from the left gastric artery. But the rupture of the ulcer in the duodenum means the gastroduodenal artery. So this is the most common question. They asking about the duodenal ulcer. They bring the patient with the pain, with the hemorrhage, upper GIT hemorrhage, vomiting with the blood, and pain decreasing with the meals. And they said which is the commonest artery to be affected in this patient. It's gastroduodenal artery, of course. So we have obstruction in the pyloric canal or duodenum as well, because the raising edge of the ulcers. Also here the perforation is most common in the duodenum, in the anterior wall of the duodenum, most common than the posterior wall, but it still can happen in the posterior wall. Anterior duodenum ulcer can perforate into the abdominal cavity potentially and leading to the pneumoperitoneum. Pneumoperitoneum, that means there is an air in the under the diaphragm here and other side here. We see the separate air layer. See this black layer here? It's separated from the chest and the chest cavity here. We have a two line. You see this line here and the other line here. That means there is a gas under the diaphragm, and the pain will refer to the shoulder because it is innervated by the phrenic nerve. The diaphragm is innervated by the phrenic nerve, and the shoulders also, somatic sensation of the shoulder also have a nervation from the one of roots of the phrenic nerve.